they told me I had 10 slides to talk about all of older AML, which just, maybe if I only put the randomized data in, I could do that. So anyway, I said science or craft, and that's because, first, thank you very much for being here. Science or craft, because a lot of it is, we're, again, sort of feeling our way, and I think in this particular patient population, there's a lot of room for discussion with your patient. I think a lot of this really calls on you to be a doctor that looks at the whole patient. So I was always told to start with a case, and that's what I'm doing. This is a 72-year-old lady who I saw. She has hypertension, history of osteoporosis, and had breast cancer at age 64 with adjuvant radiation therapy. She had a PS about 1. She has some fatigue, back pain. She can still go grocery shopping, but she leans on the cart a little bit. She just says that back pain, and she doesn't feel she could do things the way she used to do before. We went through her performance status pretty carefully together when I came up with this one. I asked her all the right questions. I would point out sometimes people's performance status is different if you decided as a doctor versus if you give them a pamphlet and say you fill out your performance status. So that's one thing to keep in mind. Her signs and symptoms, she has pancytopenia. Her ANC is low at 0.23. She has anemia and thrombocytopenia, 32% circulating myeloid blast, which we see when she walks in the clinic. She has an LDH of 422 with night sweats. She hasn't been febrile. Her cytogenetics are pending. And pathology calls me and says this is a treatment-related acute myeloid leukemia. So she asked the questions that all of your patients are going to ask. What are her chances? What will this, if I give her intensive therapy, will that improve her life? Will that extend her life? If it's intensive therapy, what kind of treatment should I choose for her? Should she think about a stem cell transplant? She had a niece who had a stem cell transplant. Is that the kind of thing that someone would do in her age group? And what about clinical trials? The other thing, so I work in Wisconsin. Half my patients come from more than about 300 miles away. For her to get transfusions regularly would need to be locally, but coming down for a stem cell transplant, she would have to drive her camper down and park it at the state fair, basically, because she's a long way away from a transplant center. So how many people in this audience get cytogenetics completed before they decide on therapy for a patient like this? Yeah, so that's pretty hard to do, right?
Well done.
The one thing you can do is get FISH testing done, right? So you can have your center do FISH testing, and that can at least pull in one of the key components here is what her cytogenetics are, because she has treatment-related disease, which automatically makes her high risk, but some of your choices may decide on what her cytogenetics are. When I sit down with somebody, I try and at least put in my mind a little bit how I would understand her risk and outcome. And these are 3 key, relatively old, but key studies that can help you look at patients arbitrarily, we're calling old or over the age of 60, but look at their risks and some of the outcomes by doing retrospection of large numbers of patients. In this, for example, study out of the Germans, they took more than 900 patients. Now, these patients and all these studies are what happens if you gave somebody intensive induction therapy. This first study gave people, these are people over the age of 60, enrolled in a trial where they got 7 and 3 with daunorubicin at 45. They got 2 cycles, although I will tell you a good number of people dropped out after the first cycle, either because of toxicities or because of death. They automatically got 2 cycles and then a single cycle of consolidation. Their CR rate was 50% with a 5-year overall survival of 9.7% and a 12% treatment-related mortality in the first 12 months, or the first 30 days. But what they did do is look at the retrospective variables of these included. What they interestingly found is if you look at the people with favorable cytogenetics, these variables don't matter at all. If you look at the people with poor cytogenetics, the variables don't matter at all. These variables really discriminate in your intermediate risk group and can help describe an overall survival in that intermediate risk group of between 35 and 40% versus in the low teens percent. And so using these in a patient that had intermediate risk disease, which the paper defines where the cytogenetics fell, but that might be helpful to say, look, we're looking at an overall survival in 3 years in the mid-teens or something in the mid-30s. And so using a model such as this, Wheatley, who looked at 2 British studies, look again, large numbers of patients, and they divided them into good, standard, and poor risk. And again, there was range here because of the validation in that second study. And then in the Klug paper, again, some German data, they developed a web-based scoring system looking at the kind of things we think about de novo versus secondary. And some of these involve things that you're not going to have when you're making that first decision. It's hard to get NPM1 positivity back before you have to decide on therapy. Although I will say, there's a number of older patients that you do not need to start treatment on that day. And if it's a matter of coming up with the right thing, someone's hypoproliferative can be supported through it. There's no reason to rush before you have the right data. What about describing this woman's likelihood of treatment-related mortality? So there's a lab at University of Washington, Roland Walter's lab, that's developed a web-based tool that I find particularly helpful when I'm talking to patients. It's at this website here. And one of the things that's nicest about this is that it uses large numbers of studies. Again, these are all people who were treated intensively. Uses large numbers of patients from MD Anderson and Seattle, and Schwab. And all these things are things you had at the day of diagnosis. So you don't have to wait for anything. Again, this just what you can do then by going to this website, you plug in performance status, age, etc., and it pulls out the likelihood of treatment-related mortality, which is death within 28 days. And it gives you a calculated score. So in our patient, for example, she has a likelihood of a 7% death. According to these things, if she was treated with intensive chemotherapy by Schwab or the MD Anderson. So again, those are all caveats. Those people that got put on clinical trials may have had a lot of other invisible performance status that was better because they got on there. So there's some bias in this. But again, I find this helpful when I'm talking to patients sometimes and they ask me these specific questions. Now I will tell you, one of the things that I think about this just tells you about death. This doesn't tell you about, am I likely to have a good quality of life afterwards? Am I going to end up in a rehab facility? What's this going to mean to my family? Those things I think get important when you're dealing with older patients. But again, I find, and again, this is the tool, I find it's a helpful, thing to bring into the conversation sometimes, even if it has caveats related to it. So what about a geriatric assessment? There's been an increasing number of people using tools with formal geriatric assessments at the time of diagnosis to, again, give an idea of what's the quality of life change, what it can inform this initial decision making, and I think on a clinical research basis, it can also provide incentive for us to do some co-interventions, maybe some kind of exercise therapy, dietary changes, etc., that might improve the geriatric performance. I think the best model of this is developed by Heidi Kleppen at UNC, where she did a prospective study of about 70 patients who were over the age of 59. Their doctors had already told them they were getting cytotoxic induction therapy. They got a 7+3 regimen. And before they got that, after they'd been transfused, so after they'd sort of been stabilized in the hospital, they had geriatric testing, including cognition, physical performance, and a 4-minute walk test. It turns out that both really mattered. So if you look at a patient with poor cognitive function, they use this mental status performance. It's not the MoCA, it's like the MME or something. If you were less than a score of 77, your overall survival was very significantly different than those with the higher. Again, if you look at this physical performance battery, which included getting out of a chair, standing balance, etc., again, a significant difference. Now, this has not been prospectively proven. First off, this doesn't say how these people would have done if you'd given them any other kind of therapy. So maybe they also would have done poorly if you gave them hypomethylating agents or Aracene. The second thing is that this doesn't say, can we change this at all? Again, we can't say that this is something that's ready to derive, well, if this is the case, I'm not going to give them that therapy, but it is informational, and it might help inform your conversations with patients. So it's not yet been replicated, and it doesn't tell us what would have happened if those individuals got lower intensity therapy.